Well, it's exciting to be here today for me, and I really agree with the comment that chronic pancreatitis has been overlooked by the importance of pancreatic cancer, and I think this is very apt that we come together and talk about some of these issues. I'm going to talk about the discovery of genetic insights into chronic pancreatitis pathogenesis, and one of the things I'm becoming more and more excited about is this molecule here. This is the cystic fibrosis molecule looking down through the pore, and this is the 25th anniversary of the discovery of the cftr gene, and it turns out to be important for reasons you'll see shortly. Now, the history of genetics is going to be given on one slide, and I'll just make a few comments on it. 25 years ago, the cftr gene was discovered. This is a severe mutation when you have mutations on both alleles, and it causes cystic fibrosis of the pancreas. That's where the term cyst and fibrosis comes from. And it begins in utero, so it's almost a congenital disorder, but there's continued destruction of the pancreas over the first few years of life in most cases. In 1996, the discovery of the trypsin gene, PRSS1, that caused hereditary pancreatitis was the first pancreatitis-associated gene to be discovered. This is not a multi-organ disorder. It is only the pancreas, and it provided us a number of insights, and I've highlighted this because I'm going to make some additional remarks in a few minutes. In 1998, the importance of cftr in atypical CF was highlighted, and this is where you have mild cystic fibrosis, but you have the pancreas that's disproportionately affected. And most of these patients were drinkers and smoked, but it was also observed that some patients only had one identifiable CFTR variant plus a SPINK1 variant, and that is important as well. The SPINK as a disease modifier was identified by several groups. Then in 2003, a calcium sensing receptor, which was only disease causative if there was also other modifying factors. The chymotrypsin C gene, which was described in 2008, is also complex, where by itself it doesn't do anything. You have to have combinations of 2, 3, 4 mutations and other factors before it becomes important. In addition to that, there was a discovery of a CFTR variant that specifically hits the pancreas and not the lungs. And this is highlighted. I'm going to speak about this as well because it causes a selective bicarbonate secretory defect, and the bicarbonate is important for pancreatic secretion but not lung secretion. I'm going to talk briefly about the Claudin-2 gene, which we discovered in the first genome-wide association study of pancreatitis, and then there are additional genes that have been identified. Very importantly, the carboxypeptidase A gene, which was just described in Nature Genetics this summer, and it shows that if you have the unfolded protein response and stress of the pancreas, that can drive chronic pancreatitis. And then there's been a number of other genes that have been described. And so what we're seeing is that we have a whole series of risk factors that come together in different combinations and explain the vast majority of cases of recurrent acute and chronic pancreatitis. And what we're trying to do is put our arms around this problem and think about it in a way that a general practitioner can make an evaluation, get the appropriate diagnostic test, and get specific information about how to help this patient from developing advanced chronic pancreatitis and being sent to Barbary. So the problem of chronic pancreatitis is illustrated in this CT scan. This is a patient I had at the VA that I really struggled with to help him. He had almost every known complication of chronic pancreatitis, and I learned some very important lessons from trying to help this patient and who ended up dying because he couldn't get narcotics after having a severe attack over the Easter vacation, and so he went to one of his friends who suggested that heroin actually was a good pain reliever, but the guy was not a pharmacologist or pharmacist and gave him the wrong dose and killed him. What we see with chronic pancreatitis is a syndrome that has scarring, but it's highly variable, maldigestion, late in some patients, not other, diabetes in about half the patients, but not the other half, pain in 40% that's constant and provides almost all the morbidity, but others have no pain, or they have mild pain that's easily controlled, and pancreatic cancer in about 15% of these patients. Who's going to get which complication, how fast it's going to advance, and what's going to be effective as an intervention is unknown. And that's ridiculous. What we're trying to do is figure out how to predict who's going to get which complication and prevent it so that nobody suffers these end-stage complications. Currently, our diagnosis and treatment is to demonstrate irreversible damage. So you can't make the diagnosis until you have irreversible damage, which is really a silly definition for trying to manage a disease. So we do repeated testing until we identify irreversible damage and then give symptomatic treatment. So this is what I struggled with this VA patient, and what I concluded and what I learned from this patient was that pancreatitis is a hopeless, irreversible condition that is expensive to diagnose and treat. The key to managing recurrent acute and chronic pancreatitis is to prevent it. And we're on the trail to doing that. So, as we suggested, pancreatitis is a complex genetic disease. There are strong underlying risk factors for recurrent acute pancreatitis, which seems to be the susceptibility factor. There's strong underlying genetic risk for progression that determines who gets fibrosis and who doesn't, who gets pain and who doesn't, who gets diabetes, who gets cancer. There's also important environmental factors such as alcohol and smoking that really accelerate the process and they worsen the complications of pancreatic disease. So we believe that early knowledge of the basis of these risks could be used to target therapy and change pancreatic disease from treating end-stage symptoms to preventing the disease. That's really why we have put all of our effort together in order to understand the genetic contribution to a complex disease. And so genetics isn't everything, but it's something, and it's important. Now, hereditary pancreatitis was very informative. As I mentioned, it was first reported by our group in 1996. It's an autosomal dominant disorder, and families that have this are remarkable, especially ones through this area of the country. Our initial family for genetic linkage had 500 family members in it. So we were able to map the entire gene with one massive family that went back before the Revolutionary War. And thank goodness for Bibles and for grandmothers, because the family Bible and the grandmothers knew everything about everybody, and it was just remarkable. The grandmothers, of course, couldn't stop just telling us the symptoms. Boy, we learned a lot of interesting family secrets, but those have not been recorded. What's remarkable about hereditary pancreatitis is it has one gene. It's the worst gene known for pancreatitis, and yet only 80% of individuals who have this genetic mutation ever have a symptom, and it doesn't occur until they're about 10 years old on the average with a wide range. So there's other factors that are very important in initiating acute pancreatitis, but once they've had their first attack, something changes because they start having attacks frequently and more frequently until their pancreas is destroyed. And in fact, half the patients with acute pancreatitis end up with end-stage chronic pancreatitis. The other half don't. They have recurrent attacks of acute pancreatitis and then completely recover. The other thing that's interesting is that a subset developed pancreatic cancer. And about 40% were projected to eventually get pancreatic cancer. But what we realized is that smoking was the major driver. And if you look at the patients who have no smoking and have not developed diabetes, the risk of pancreatic cancer is really low. It's probably 8 to 10%. What's also interesting is that the 8 and 10% is not evenly distributed. We have families with over 100 individuals in it that have never had a case of pancreatic cancer. And they've had severe disease from childhood, and yet they just don't get cancer. In others, cancer's all over the place, and it tends to track in certain lines of the family, suggesting that the cancer risk is an underlying genetic factor as well. So we're beginning to understand the hereditary pancreatitis as a model of other forms of pancreatitis as well. Now, what I've described to you are some of the extreme cases. What's in the middle just looks like complete confusion. The disease gene is the trypsinogen gene shown here. This is the molecule with two globular domains. This is the SPINK gene here, which is a trypsin inhibitor. It's a suicide inhibitor. And this is the key molecule that causes hereditary pancreatitis because it links the front and back portion of the enzyme. Most of these hereditary pancreatitis mutations are gain-of-function mutations, so that you end up with a supertrypsin that is turned on and cannot be turned off. It turns out that there are other mutations that have a much milder phenotype, and it has nothing to do with trypsin activation. It has to do with the unfolded protein response and putting the acinar cells under stress, because trypsin is the number one produced protein, and there's massive amounts of unfolded protein. It causes the pancreas to have this stress response, which can drive chronic pancreatitis. So the gain of function, increase activation or decrease inactivation. What we learned from hereditary pancreatitis was actually very important. We learned that for chronic pancreatitis, acute pancreatitis comes first, and chronic pancreatitis comes later. And so what we had been taught in school way back in the early days, which is like in the 80s, is that chronic pancreatitis develops first in alcoholics, and acute pancreatitis is complications. And yet hereditary pancreatitis suggested that that was wrong. It's just the opposite. And it also suggested a two-hit model, which I called the sentinel acute pancreatitis event, because the patient does fine carrying a trypsin gene until they have some stochastic event that causes injury to the pancreas, activates trypsin, you get your first episode of acute pancreatitis, and then everything changes, and you either recover or you get worse, but that factors that determine whether or not you progress is the second hit. SPINK is very important, but it turns out it's important in almost every type of pancreatitis. It's a secondary modifier. It does not itself cause pancreatitis, and I'm not going to speak about this further. So this is the natural history of hereditary pancreatitis, and what it shows us is that acute pancreatitis occurs with a median age of about 10, and then the effect of advanced chronic pancreatitis with malabsorption and diabetes and pancreatic cancer come a number of years later, but it only comes in a subset of the patients. And the reason why it only comes in some patients and not the others is important. So we put together a model called the Sentinel Acute Pancreatitis Event Model in order to help us organize all the events and all the processes so we could study each one by itself and then link it together. We call this reverse engineering. And I've had some criticism about this because some patients don't fit into this model because they've never seen an episode of acute pancreatitis and they show up with chronic. And there's a famous saying is that essentially all models are wrong, but some are useful. And we found this one to be useful. And what you see is that you have individuals with a susceptibility factor, such as a PRSS1 mutation, that are completely fine. But it could be any mutation or any other risk, like heavy drinking or smoking or others. And then some stochastic event occurs. I don't know what it is. It can be anything that initiates the immune system, because the immune system is what drives the itis and pancreatitis. Then you have acute pancreatitis, which can be mild or severe, and it activates stellate cells, which we'll hear about later, and other factors, macrophages and other things. And it usually runs its course in having a pro-inflammatory and an anti-inflammatory phase. And then you end up with a very interesting period of time in which most patients resolve, but others have factors that cause progression. Stellate cells activation causes fibrosis. Failure for the acinar cells to regenerate causes atrophy. Loss of islet cells causes type 3C diabetes. Some patients have an alteration in the nerves response to pain, and they get a chronic pain syndrome, and others begin the pathway toward pancreatic cancer. And so these do not go in parallel. They're not surrogates of each other, and they have to be tracked independently. We recently finished a study to look at the correlation between pain and fibrosis, and what we found was there is none. They do not correlate at all. They're completely different processes. And lo and behold, the stellate cells in the nerves are not the same beast. They're different systems, and there are different factors that are important. Now, does this work for other types of pancreatitis, such as alcoholic pancreatitis? So Dheeraj Yadav, who will be speaking later, did a very nice study, and what he showed is that if you look at alcoholic patients, you see that most of them start with acute pancreatitis, 30% get recurrent acute, and about 30% of those end up with chronic pancreatitis. And so we see the same type of process where initially you have an injury, some get better and some don't. And there is a progression that can be seen that is parallel to what we see with hereditary pancreatitis, suggesting that this is an underlying theme. As a matter of fact, this happens with almost every type of pancreatitis. So in this study that came from over 7,000 patients in Pittsburgh using administrative data, Dr. Yadav showed that if you look at an episode of acute pancreatitis and you look at the months following that, the development of recurrent acute pancreatitis begins occurring, but it depends on the etiology. So alcohol is very bad. If you have a biliary and you take the gallbladder out, the chance of a recurrent attack is low. With hereditary and other factors, it's intermediate. So there is an increased risk of recurrent pancreatitis after the first episode. Now, what's important here is that we know when this occurs, and this gives us a chance to intervene in those subset of patients that are likely to develop recurrent attacks. And we're trying to figure out who they are in advance, but it's about a third of them, so we know that that is an important effort. Now, what is the relationship between recurrent acute pancreatitis and chronic pancreatitis? Is the hypothesis that we have for hereditary pancreatitis correct? And what Dr. Yadav showed is yes, if you look at the risk of developing chronic pancreatitis, recurrent acute pancreatitis is driving the process. And Paul Lankish in Germany showed the same type of thing. He had more of an alcoholic population. This is a very mixed population, but we're seeing an important theme here. And what are the factors underlying this process that drive chronic pancreatitis, the entity that we're trying to prevent? So now we're beginning to break down the process into its component parts, and it turns out that the pancreas is really simple. What happens is there's a stimulation with excitation secretion coupling, and so you get the acinar cells shown here in the little black balls being released, and they go through the duct down into the duodenum where trypsin's activated and the meal is digested. And we can actually break down the risk for acute pancreatitis into two groups. One is the acinar cell, and the other is the duct cell. Now, this is important because we target therapies very differently depending on which cell type is being affected. Is it calcium dysregulation and trypsin activation, or is it a flushing problem? Is it having difficulty getting the enzymes out of the pancreas? And our therapies and directed treatments can be cell-based rather than just global, arbitrary, and random. This way we may be able to prevent recurrent acute pancreatitis. So what we've been doing is mapping out all these different factors into pathways, and I've focused pretty much on the trypsin pathway. The other that I mentioned I think is very important is this ER stress from the unfunded protein response. The paper by Witt et al. In Nature Genetics on the carboxypeptidase A is an outstanding example and really a prototype of this disease. What the secondary effects are important, but in this case, they all converge on the stellate cell and drive fibrosis. We would anticipate there would be other factors that would be important for causing chronic pain, causing diabetes, causing cancer risk. And now we can begin to compartmentalize and put it together. Now, I don't want anybody to memorize this, but what I want you to know is we have something very advanced that came in the second part of the 20th century called a computer. And the computer can track all of this in every patient and begin making predictive modeling so that all you need to do is to do genetic testing, which used to cost thousands and thousands of dollars. Now it's like $500. And what we're trying to do is put the pieces together so you get a simple answer to a complex question and can direct effective therapy at the very onset of symptoms. So the susceptibility factors, I've mentioned a couple of others that are important for progression are listed here, and there are some additional new ones that the roles have not been completely defined yet, and we're continuing to work on those. What I'd like to talk about is some new findings for the CFTR gene as part of a happy birthday celebration, and something that turns out to be very important because these are probably 3 or 4 times as common as other mutations that are known to be severe. These were previously classified as benign, but they were classified by pulmonologists, and so they were wrong. So this is what a CFTR molecule looks like. This is was done by a group at University of Pittsburgh in the computational biology group, a guy by the name of Ignacia Janral. And this is what the CFTR molecule looks like. It's classified as an ABC transporter, but it's really a channel. It's located on the apical membrane of a variety of epithelial cells, and so the plasma membrane would be situated like this. Down at the bottom, you see the regulatory regions that are important for its function. So it's a regulated ion transporter, and the regulation is actually very fascinating because not only does it open and close, but it actually can change three-dimensional directions to become a bicarbonate channel instead of a chloride channel, which was not known. And so this is what the molecule looks like, and if you see where the flexibility is, you can begin understanding where within these channels there are potential defects that are going to disrupt the movement of certain ions. Now, Minggu Li, who is a cell biologist in Korea, came up with a very interesting observation, and that is in low chloride conditions, there is a molecule called Wink1, which is a sensory molecule inside of the cells, and it senses when the ion concentrations are changing, and when it becomes activated, it opens up different types of channels to protect the cell, and it opens up CFTR, but it actually changes CFTR from a chloride to a bicarbonate channel. And so we did some collaborative studies to find out if some of the genetic variants we were looking at that seemed to be associated with pancreatitis affected this Wink1 signaling. And what you see here is a diagram that shows a variety of mutations that we identified from our NAPS2 group. And what you see on the far right is CFTR in the normal state, and what you see as the y-axis is a ratio of bicarbonate permeability to chloride permeability. And under the normal state, there's only about 1/5 the permeability of bicarbonate to chloride, so bicarbonate doesn't go through very well, but chloride does. With Wink activation, suddenly the bicarbonate becomes highly permeable, even more than chloride, and the thing completely switches to a different type of channel. However, if you look at the mutations that we recorded as being associated with pancreatitis, they screw up the switch. So you can't turn into a bicarbonate channel. And the interesting thing about the duct cells is that you can't get chloride in on the basolateral surface, only bicarbonate, because of a sodium bicarbonate cotransporter. And if you have this mutation, you can get chloride out, but not bicarbonate. And to get either chloride secretion or bicarbonate secretion, you have to get the ion in on one side and out on the other. So you have a mismatch where you can get the bicarbonate in, but you can't get it out, and you get chloride out, but you can't get it in. And you end up with a duct that doesn't secrete. That's bad. That causes pancreatitis. So not only is the permeability affected, but the conductance is affected as well. Now, how does this work? Well, what we did is, first of all, we looked at a number of cases, about 1,000 cases and controls from our NAPS2. We went through the literature and looked at all the different variants that anybody had ever previously reported as being in pancreatitis with a CFTR mutation. And we found 43 of these. So the pretest probability that these would be associated with pancreatitis was high. What this shows is the CFTR variant on the far left, and then the odds ratio and p-value of a autosomal recessive disorder or linked with SPINK, which we also is important, the N34S mutation. And strikingly, what we found is this subset of patients that have a bicarbonate deficit in chloride secretion is highly associated with risk of pancreatitis. So from a statistical standpoint, there's a link, and now mechanistically there's a link as well. So how does it work? Well, it turns out that 5 of the variants were located in the hinge region so that the molecule, which is normally flexible, gets stuck and can't switch from a chloride conformation to a bicarbonate conformation. 2 variants were in the chloride channel itself. So this one, panel C and D, shows one of them. And what happens is it causes a rotation of the protein, so you've got a big side chain sticking out in the middle of the channel. Now, for gastroenterologists, this is like having a giant polyp in the colon that's causing constipation. And it's constipation of the chloride, of the duct. And since the size of chloride is much smaller than that of bicarbonate, it causes a selective deficit. And then there's one here, which is R117H on the outer surface, and that is a strange bird itself. We're not exactly sure how that works, and a lot of people have worked on that and don't understand exactly how it works. But we're beginning to understand that there's something very important. We also know that these CFTR variants are associated with pancreatic divisum. So if you have both a low head pressure and a high distal resistance, you're at risk. Smoking turns out to be important as well. There's a couple very interesting papers that show that components within tobacco smoke specifically inhibit CFTR conductance. So if you have a variant that decreases the ability to secrete bicarbonate and you smoke, it's bang, bang, pancreatitis. They're additive in their effectiveness. So a variety of factors are important. Now, what's important about these 2 factors? We can change it. We can fix it. We can't change the CFTR, but we can reduce the risk in people that have combinations of factors. So we've learned from CFTR that there are at least 5 different mechanisms in which CFTR variants can cause pancreatic disease. The first one is cystic fibrosis, and this starts in utero as soon as trypsin is expressed and is cystic fibrosis. The second one is atypical cystic fibrosis, where you have the mild variable mutation, so you have mild mutations, but if you have other factors in the pancreas, such as SPINK, smoking, and others, you can get pancreatitis. There's also these new variants, the bicarbonate defective variants, which are very common. And if you have them, you end up with idiopathic chronic pancreatitis. But what's interesting is that it turns out that other organs also use bicarbonate rather than chloride, and that includes the male reproductive glands and the sinuses. And so we checked to see whether or not patients with chronic pancreatitis and these bicarbonate defective variants increase the risk of sinusitis, and it more than doubles the risk, highly statistically significant. And does it cause male infertility? And the answer is yes, by a risk factor of 400. That's an odds ratio, not of 2, not of 4, of 400. And so we have a syndrome of organs that use cftr for secreting bicarbonate that are specifically affected as well. And so these other organs need to be considered. And then the severe or bicarbonate deficient plus SPINK will cause effects in the pancreas only, and smoking and other factors are also important. Now, one slide on this other gene. There's a risk factor for alcoholic pancreatitis that was discovered on the X chromosome, and it is claudin. So we don't know exactly how it works, we just know the locus. So what's interesting is 16% of men and 10% of women are heavy drinkers. Men only have one X chromosome and Y chromosome, and women, of course, have two X chromosomes. Since this is a risk factor on the X chromosome, men have it as an autosomal dominant risk. They only have one X chromosome, whereas the risk for women, you have to have it on both chromosomes. It's recessive in women. So the overall risk of alcoholic pancreatitis, based just on this factor, is 4% of all men are at risk, less than 1% of women are at risk. So this may partially explain why men are more commonly have alcohol-associated chronic pancreatitis than women do. They have both more drinking, and they have a dominant disorder or dominant risk rather than a recessive risk. But by testing for this early in patients that are drinking and have abdominal pain, we may be able to identify those patients who are at high risk of developing chronic pancreatitis. This could be an early warning and a chance for intense intervention. And as we understand how the claudin increases risk, we may be able to provide targeted treatment to prevent these people from having a horrible disease. How do we put this together? Well, as I mentioned in our current approach, in our clinic, we have the first symptom. We start doing testing. Okay, your pancreas is a mess. We have a diagnosis, and we're going to give you symptomatic treatment, and the patient is disabled. What we're proposing is something different. What we want to do is to do genetic testing early, find out what's driving the process, give targeted therapy aimed at the etiology, and in these cases, we believe that they will have less symptoms and actually be better. So what we know is that recurrent acute chronic pancreatitis are complex genetic disorders. Genetic information is critical for personal care of medicine with pancreatic disease. Specific genetic information must be available to healthcare professionals freely and immediately. You have to know what the mutations are. The management should be easy. It turns out the complex diseases, if you find out that you have some of these mutations, they don't mean anything outside of the context of the disease. We need big structured data sets in order to better define exactly what the risks are, under what conditions, and what kinds of factors seem to improve outcomes, and that the interpretation of the data on a case-by-case basis remains a challenge for the practicing physician. But we have computers and the internet, and we believe it's going to be possible to provide precise, useful information to physicians immediately as they make early diagnosis based on risk and provide treatments to prevent the development of a disease that nobody can cure. In concluding, I want to thank our pancreas team at the University of Pittsburgh, which look really nice here, but what's really behind the scenes is very important, and that is the North American Pancreatitis Study Group, over 2,000 patients carefully phenotyped and genotyped from centers from around the United States, with collaborations from England and Germany, and that's been extremely effective. If you're interested in more information on the genetics of pancreas, the Pancreas Fest group is co-sponsoring the 8th International Symposium on Inherited Diseases of the Pancreas in Israel on June 8th, linked with the European Society for Pediatric Gastroenterology, Hepatology, and Nutrition, and information is available there. And we also would invite you to Pancreas Fest in Pittsburgh in July if you'd like to join with us in trying to make a difference and figure out how to prevent the development of these diseases. Thank you.